Welcome everyone to another edition of our Unfiltered Productions podcast. With me today is again Cindy Kraft. I'm Sherry Teague. We're the founders and owners of K&K Healthcare Solutions, and we were just starting a rant in a conversation about a potential customer. And Cindy asked this question, and I'll pose the question: what have we done to clinicians? What have we done to start a care clinician, Cindy?
Well, just a series of events over the last few days and thinking about, agencies that are struggling with respect to plan of care. They want to get it cleaned up. There's too much in there. There's lack of focus there. Hearing from outsourced providers like ourselves, the frustration about trying to code something because, how come the clinician isn't able to identify a focus of care? And then it hit me, Sherry. It's like, what have we done to them? How is it that skilled nurses and therapists going out to the home to open a case struggle to document what is the focus of care? And I think it's because we have operationalized the heck out of this to the point that they don't know what to do. Wait a minute, we have to make sure it fits with PDGM. Hold up, does this need to align with the face-to-face? I mean, even that issue of the face-to-face gives leeway that if I go out to admit this patient, and yeah, I'm glad the doctor gave me this opinion of what they think the reason is, but if I find something completely right, I mean,
90 days ago, yeah.
Right. So in good faith, they gave this information. I go out there and I figure out, no, I mean, yeah, they do have the heart failure you put as primary, but now that I'm in the home 60 days later, their diabetes is the bigger issue. I mean, the heart failure's in play, but not as much as this mess I found. And what do we see? Well, a nondescript statement, or I put heart failure because it matches the other thing. And but then I look at the plan of care, and there it is. It's all about diabetes, which now doesn't fit with this. So it's like, how much of a mess have we made this that clinicians feel powerless to say, why am I here? That seems like it should be a very simple question. And yet we see that from our coders routinely, Sherry, that, oh my gosh, we need to send them a webinar about, writing a good narrative and what is the focus of care. But it just hit me like a ton of bricks yesterday. It was like, what have we done? This is not a super complicated question. And if it doesn't align with the face-to-face, then I need to reach back out to the referring physician, let them know what I found, and this is what we're going to be doing. I should be doing that anyway, because my plan of care is going to have a bunch of diabetes stuff in it now that doesn't necessarily fit with what they sent. So I'm going to do that anyway. But I feel like, if you look at what is the focus and the coding and PDGM and value-based purchasing and OASIS accuracy, I think we've made this so convoluted that we now have to have all of this external stuff and not empower the core. I got to have a robust review team. I got to have data analytics. I've got to have QA check this. I've got to have all of this to make sure this gets done right. But the person who is there with the patient, who knows what they need to do, have they just lost their sense of ownership, their power? As we've said for over a decade now, the front line drives the bottom line. But have they lost their voice? Have they just kind of given up, Sherry, with, okay, what does the coder want me to put? What does the QA tell me to put? All right, they corrected my OASIS. Fine, whatever. I agree with that. Yeah, I'll go to another meeting. Yeah, okay. All I ever want to do is take care of patients. Isn't that what we're all supposed to be doing? I mean, the effort is for them.
I'm going to say something about that apathy piece. Okay. So clinicians go out into the home. Home health is one of the only settings where they're not supervised. They don't have a peer professional next to them. They don't have overhead that the agency has to pay for. They are there under their own agency. They are their own care provision team at that moment. Right. Mm-hmm. What I think is the scary part of all this overanalyzation of I say overanalyzation and we analyze. So there you go. An overanalyzation of the start of care process is that we've created clinicians who are apathetic and possibly usefully, for the first time in my life, I'll say this, passive aggressive. Okay, usefully passive aggressive, saying, I'm going to be in this house and I'm going to provide the care that this person in front of me needs. And my dogs are barking right now, so y'all know this is unfiltered. I'm going to provide the care that my patient needs, but I'm going to give the office what they want. And so the scary part is that then you get into a denial or an audit situation, and the care that's being provided in the house has no resemblance to what's on the plan of care, has no resemblance whatsoever what's on the OASIS. And then when we go out and we teach folks, or we have our educational courses, we ask the clinician what their job is in the house, and none of them really understand what the big picture is. None of them understand how important keeping someone out of the hospital is, when you should be arming your clinicians with a set of questions. I walk in the door, what is the most important thing with this patient that's going to keep him out of the hospital? What is it that I need to take care of that's going to keep this patient at home? And that apathy and that passive aggressiveness that I know is occurring, because we see it later on in the patient notes. When we're doing our audits, we'll look at the start of care, we'll go, oh, that's pretty, it's pristine, it's been through all the rigmaroles of the office and the quality assurance in the office. But then we look at the documentation in the visit notes, and it's unrecognizable to what's in the documents of the start of care. Any reviewer from CMS could come along and find that same thing, and then they want to check back, right? They want some of that money back, because there's no match, there's no congruity. So I'm with you on that, and so it's just maddening to me how overanalyzed this stuff is, and how little tools and power we're giving to the folks that are actually out there collecting the information. That is something that we see, that disconnect every day.
Well, and I think that drives not only the passion people can sense in this Unfiltered today, but my frustration as an OASIS educator is I don't want to keep talking to QA level people and leadership level people. I love you all. If you're listening to it and watching this, I do. But my gosh, it's got to get down to that frontline clinician. That information, if you think about it, regulations, definitions of homebound, conditions of participation are all meant to be understood in the hands of the clinician. They're the ones out there with the patient. They're the one who has to understand how they qualify for this setting and what that really looks like. But we've taken so much and said, well, it's easier to make check boxes. It's easier to do this. It's faster to do that. It's faster to have my back office rewrite your plan of care and sign it for you and get it out the door so that we can drop bills and do everything else. And I think it is I believe the nurses and therapists and aides and social workers are out there doing the best possible job, more often than not, that they can for this patient. But you're right. I think they're doing it with just humor the rest of you to just keep you off my back so that I can get this done. And then we come at them later when that denial happens and blame them. They did homebound status wrong. They checked all the wrong boxes. Hold up. I've seen boxes available for homebound status that says patient refuses to leave the home. Excuse me, that's not even a valid reason. And yeah, our clinicians should know that about homebound status, but why on earth are you giving them a tool that allows them to check it? They checked it. You're in trouble now, and you blame them for checking the box. Hold up. I think this is about getting back to some of those basic things to demystify this stuff. Because when I hear clinicians complaining about all this onerous extra thing, we've got a problem. Data collection is a routine occurrence. Guidance is available so that I know what I'm doing. The CMS is asking you to define what is the focus of care and work collaboratively with the physician. That's the expectation. I think we've just made it so hard that people give up. And I think we have to do something better than this. We can't keep sticking more Band-Aids on top and then hoping the person who's literally buried in them right now can figure out what they're supposed to do.
But I'm going to speak directly to the clinician now. Yes, it's tough being a clinician in home health, especially if you have an over-regulated back office that's trying to possibly manipulate information to meet the payment guidelines. That is a tough thing. The payment guidelines are tough. They absolutely are. But for those clinicians, I want you to listen to me right now very, 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 very closely. If you've become passive aggressive, if you've become a little bit manipulative in the way that you treat your patients versus the paperwork that you turn in, always understand this: it's your name on that documentation. No matter what happens, no matter how many fixes, every plan of care you sign, every OASIS you sign, all of that comes back to you. So when you document on those things, you need to be wary and be aware of the fact that you may be seeing that documentation again in the future. and it's going to be your license that would be in question if you have a disparate care provision versus what you turned in for paperwork. So stand on that hill, plant your flag, die on this issue, and protect that responsibility. Cindy, I think that's what people sometimes forget, especially clinicians. They sometimes forget when you have a large organization that's telling you to do something one way. You need to know the rules of the game. You need to know the rules of payment. You need to know the rules of your license, and you need to protect them. So clinicians, don't get passive aggressive. Don't get apathetic. Make sure that you are writing what you see and stand by that. And be what's the word I'm looking for? Be steadfast in doing that. So I think that's super important.
One thing I would add to that is the balance of, if I'm going to plant my flag, I need to plant my flag correctly. I need to know what those regulations and rules are. I need to understand the payment methodology. I need to do that, because I've seen clinicians plant their flag in the wrong spot. It is, you are not changing that OASIS answer when the guidance clearly shows that their position is incorrect, that I am not going to do X, Y, or Z. Wait a minute, that is an expectation of the conditions of participation. So planting flags is great. Just make sure you have the right information, because this is a collaborative issue between agencies and clinicians. We all need to be working from the correct set of rules and the correct understanding of those. And when there's inconsistencies, one side asking the other, where did you get that from? Or what regulation are you citing? I want to see the actual source information, can alleviate a lot of this, because I see angry clinicians and I see frustrated leadership about, they won't do what I say. Is that really what the regulation says? And if it does, and this is the guidance we have, to just say, I don't care, I'm going to answer the OASIS the way I want to, is disruptive to everything, because CMS believes when you send that information in, you've done it with full knowledge of what the instructions are. So your answers have to be the correct ones. So if they say somebody's really fine and you want to provide care, why would I pay for that? Your answer said they were good. And if your answers don't make sense, then the data we see come out in models like value-based purchasing, in star ratings, they're going to use the data that they have. And if it's incorrect, we see ramifications of how those models play out. So it's a lot of responsibility, but I want to wrap it up, Sherry, but there's a reason nurses, therapists, aides, and social work stay in home care. It is not because we're gluttons for punishment. It's because we love interacting one-on-one with patients, of seeing meaningful impact, sometimes over small things that we don't even think is a big deal, moving something over, making something a bit more accessible, having that conversation with them that allows them to safely manage a pet. Those are huge things that validate what we do. We have to bridge that with showing the value to the payer, because they have every right to ask about that, but not losing the fact that the whole reason we do it is because we know we're making meaningful impact in patients' lives, and that regulations are not there to make that worse or to ruin it or to take it away, but they give us that communication to be able to explain, we know what we're doing and why, and then everybody can just move on.
Exactly. And understand that our paperwork in home health is the payment for the privilege, right? The paperwork that we have in home health is more than a lot of other settings, but it's a payment for the privilege of caring for patients one-on-one. And if we can change our paradigm and remember that part of that privilege is documenting accurately, is documenting to the needs of the patient and being consistent, I think that it changes our mindset towards that documentation. And so, so make sure that you pay the price for the privilege, and make sure that if you have any questions, reach out to us at K&K Healthcare Solutions. And our website's easy, knkhelp.com. We will help you get through this. We'll help you to facilitate your growth in this space and your growth in your understanding. And we appreciate the privilege of being in front of you guys. And thank you for attending this latest Unfiltered production. And I hope that you enjoy when I catch Cindy on a rant, or one of us catches the other one on a rant, that we turn on the recording. Thanks, everybody, and be safe out there.
Take care.